दूसरे से, है ना?
हाँ ठीक है, ओके
ओके
ओके। Started, sir. Hello. Abhishek, started.
Yes, sir.
Oh. Dr. Sanjay, sir, can I start?
yes
Okay. Thank you. Hello. Very good evening to all, those who join now, and wish you a very happy new year to everyone. I'm Dr. Sanoj Raj, the Executive Secretary of International EECP Association and the founder of Oplus Healthcare. Thank you so much for joining this one. And today, basically, we have a webinar on the heart EECP treatment for heart failure patient. Let me introduce our speaker, Dr. Sanjay Mittal from Medanta. Yes, and he he completed his DM cardiology in 1994. It's so long back, and he started his career from Scott Heart Institute in 1994. Currently, as of now, from last 10 years, he is a senior director clinical cardiology and research. Along with that, heart failure program, he is a management in heart failure program and non-invasive clinical cardiology in the Medanta. And also, he is participating in teaching program, the DMB candidate and other student also. Last nearly 30 years, he contributing in the cardiology and now. And if I can say, he published more than 50 journals and all in national or international. And he still, attend more than 100 and 200 conferences in cardiology and a member of cardiology. So as of now, I can say that he has so much experience in dealing the heart failure patient, other way how to tackle the heart failure patient. He has so much experience. So we are happy to see them here, and we can get nice exposure from him that how we can treat the heart failure patient. As of we know that day by day, the heart failure cases is increasing, and for the heart failure patient, we have some limited medication guidelines for the patient, a part of EECP. But we are happy to say that a part of that we have EECP also, so that we can have we can tackle the patient or heart failure patient. So now I'll not take much time. I'll hand over to Dr. Mittal, and thank you so much and good luck.
thank you Sanoj.
Yes, sir.
I'll share my screens before I start speaking. Okay. I hope my slides are clear.
Yeah.
Okay. So thanks, Sanoj. I think this was wonderful introduction, what I am doing. But one thing I would like to just communicate to the audience that two specialties which I have developed in heart failure and cardiology is that I started the first heart failure clinic in the country, and that was way back in 1999. And that was in a Sports Heart Institute. Since that time, I've been looking at the heart failure program in the various institutes which I have progressed. The second thing is I also happen to be the first one to start the counterpulsation, enhanced external counterpulsation therapy. That happened way back in 96. And that since then I've been looking at the external counterpulsation program also for initially for coronary artery disease, but now a little bit of extension of the indications in my clinical practice. So as Dr. Sanoj said very clearly that this is a big problem which is engulfing the whole world and majorly our country. Unfortunately enough, we do not have still understanding of what the burden of problem in our country is. But we know we are the heart disease capital, the diabetic capital of the world. That means the maximum number of diabetics and heart failure and heart disease patients are there in our country. And unfortunately, whatever data we have, it is horrendous and horrifying to see that heart failure is much bigger a problem in our country. What is heart failure? I mean, I was told that there would be certain lay people also hearing this talk, but what heart failure is, it's currently defined as a group of syndromes or signs and symptoms which is resulting from structural and functional impairment of heart. And this could be in the form of either impaired filling of the heart, that means the heart is stiff enough, or is it because of the reduced pumping power of the heart? And both of them can result into congestive heart failure in the form of various symptoms and signs. So there are two things which are important. That one is there is a importantly involvement of the heart muscle and the tissues. And the second thing is there are symptoms of heart failure, which are there because of either low cardiac output, that means the heart is pumping less blood, or the filling pressure is high in the form of pulmonary edema or peripheral edema. Both of them can be heart failure. And this is big problem. Conventionally, in today's understanding, heart failure is defined or divided into two parts. First type is when there is a reduced ejection fraction, and we call it when the ejection fraction is below 40%. And heart failure with preserved ejection fraction is when the ejection fraction is above 50%, but the signs and symptoms, the breathlessness or congestion, systemic congestion or lung congestion, everything is still there. And we are having, along with the signs and symptoms and preserved ejection fraction, something to add on. That means either the evidence of increased end-diastolic pressure or hypertrophy on echocardiogram, or nitrotic peptide, which is elevated. So these are the two things which make a person have heart failure, despite the fact that ejection fraction may be normal. And then there is a mid-range, which is a controversial thing today. So some people say the mid-range ejection fraction is largely what reduced ejection fraction is. The only problem is we don't have too much of data of therapies and how they perform in the long run. So that is something which is important. In our country, this is the data from our hospital. I'm working in Medanta, the Medicity, as clinical cardiologist, director, and as well as research. And we did publish this data recently. There were 6,141 patients of heart failure which presented to us, and we found the major cause of heart failure is ischemic heart disease in our hospital. And similar kind of data has been there, varying from 37% to 72%. Nearly about 70% of people of heart failure would be having coronary artery disease. Our data was basically dependent on patients who were in outdoors rather than indoor patients, whereas Trivandrum heart failure history is majorly indoor patients, and they also find 72% patients for ischemic heart disease. So this is something which is important, and we have to dwell on this. How do we treat heart failure? We have two latest advancements on heart failure management. For last 25, 30 years, we knew that the heart failure is treated by ACE inhibitors or ARBs. Why? Because these are the drugs which block the effect of angiotensin II on the myocardium and the vasculature. On the myocardium, the angiotensin II leads to increased contractility and worsening of heart failure and cell death of the myocytes. On the vasculature, it leads to increased vascular resistance and overload the heart so that it finds problematic. And plus, on the third way, it leads to sodium and fluid retention, which leads to overload of the heart, so worsening of the heart failure. And by blocking these things by angiotensin II formation by ACE inhibitors or the receptor blockers, we can actually improve heart failure, which we have. Beta blockers, again, once contraindicated 30 years back, are the star indications to be given in all patients with heart failure with reduced ejection fraction. Aldosterone antagonists, spironolactone or eplerenone, both of them have been proven to be beneficial. So these are the third pillars. Angiotensin receptor blockers plus neprilysin inhibitors, we call as Arteries, after the Paradigm HF trial. They have overtaken ACE inhibitors for their priority on heart failure with reduced ejection fraction, because in this particular trial, it was very clearly seen over and above ACE inhibitors, Arteries were much more beneficial. So this is something which is a third pillar of the, if I'll request the moderator to actually mute all the other people while I'm speaking, please.
Cancel Abil Kumar.
Can you mute all the other people while I'm speaking, please? And the latest advancement, Dr. Sanoj? Dr. Sanoj?
Yes, sir.
Can you mute everybody else except for me?
Okay.
So the latest advancement of the treatment in the heart failure realm is for last 2.5, 3 years is Dipagliflozin. This is the drug, and empagliflozin. SGLT2 inhibitors initially originated to be drugs for diabetes, but this drug has been, a group of drugs has been so much beneficial for patients with heart failure with reduced ejection fraction that they have become a class 1A, that means priority treatment for heart failure with reduced ejection fraction. So in today's world, no prescription is complete unless they have beta blockers, MRAs, ARNIs, and Dipagliflozin. Depending upon the individual tolerance, they have to be given. So this is a good thing which has happened over the year, but despite whatever we have advanced, the unfortunate thing is that despite everything, the patient, the person who has developed heart failure with reduced ejection fraction has a horrendous mortality of 5 years of nearly 50%. So we have been able to make gains, but despite that gains, 40 to 50% would not make the 5-year span with best treatment unless we are able to reverse the disease process. So we are looking at better treatments, more treatments, medical treatments are coming up. Let's start with this case. This is Mr. SMJ, who was 84 when I saw him first, and I saw him in 2017, before the COVID came. He was diabetic and hypertensive, very old, 84, had silent anti-wall myocardial infarction, and had heart failure on 23rd November 2017. And he came to our hospital on 13th December, almost 3 weeks after this episode. He was symptomatic NYHA class 3, hardly able to take activities, go to the toilet or whatever, breathless with that. His angiogram done outside on 2017 showed triple vessel disease. This is what you see, the right coronary artery, you can see multiple blockages, very poor ventricular function, and you can see all the left anterior descending artery, you can see there multiple blockages, and this is again other view. So had triple vessel disease, multiple blockages, and also had a very poor ventricular function. This is the echo, showed ejection fraction just 25%, not more than that. And there was moderate degree of mitral leakage of the mitral.
Not moving. I'm sorry to interrupt. Your sliding is not moving.
I'm sorry?
Your slide is not moving. There is only first page is showing.
Is everybody feeling the same, or because I think it's moving for me? Is it?
No, sir. It's not moving, sir.
It's
not moving. Thank you. It is not moving.
It's not moving?
Yes, not moving.
So let me see if I can do it like this.
Yes.
Now it's moving?
Yes.
Okay. So, so this is, I had defined, I don't want to go into the details of it because I have already described it. So if you look at the angiogram, this is the right coronary artery, can see multiple blockages. It's moving now? Okay. And even the left anterior descending artery was showing the similar kind of blockages. You can see the circumflex and the LAD, multiple blockages were seen here. The echocardiogram also showed very poor ventricular function. All the anterior wall was akinetic, hardly ejection fraction 25-ish. And there was a certain degree of mitral regurgitation also, which was also adding on to the problems of the patient. So in a nutshell, this person was elderly, 84 years of age with diffuse calcified disease. Angiogram showed triple vessel, which was diffuse, and severe left ventricular systolic dysfunction was there. Ejection fraction was just 25%, has mild to moderate mitral regurgitation, NYHA class 3. His creatinine was elevated to 2.7 milligram per deciliter on 11th of December because of probably AKI or a component of CKD as well. So the issue was what to do. Obviously, the first choice was, should we or can we bypass? But when we do the calculation of the risk, perioperative risk, it came out to be very high, 15% from the Euro score, which is in Indian population going to be much higher than this. It was about 25% risk of intraoperative or postoperative mortality, which why we actually thought that something else could be important. So the question that time was what to do. There were poor angioplasty targets. Angioplasty was not the best choice, very high surgical risk, and the person was symptomatic despite medical therapy. At this point in time, something came to our head because we have been doing counterpulsation and external counterpulsation. We all would remember that external counterpulsation in 1995 was approved by FDA for stable coronary artery disease and shock. But in 2002, it also included the indications to include congestive heart failure. So in our population, what we are doing is an external counterpulsation. We do 1 hour sitting every day from below upwards. And this is a total of 35 hours protocol, which we are using until the person is requiring more, which is going to be individual variation. This is usually outdoor treatment, and we may have been doing twice a day in the interval of 2-3 hours for people who are out of stations to cut short the span of waiting period. But we prefer not to have more than 2 days break while doing the counterpulsation. Coming back to our case, this gentleman, what we did was he completed counterpulsation of 35 sittings on 15th of Jan 2018. His ejection fraction improved from 25% to 55%. His urea improved from 101 to decreased to 45. Creatinine from 2.7 to 1.1. EGFR improved from 17 ml to 45 ml per minute. And 6-minute hall walk test improved from 108 meters to 312 meters. And his NYHA class, he was saying that I have hardly any symptoms. This is the echo which we did after the completion. You can see everything is contracting well, and compare it with what we had. This is inset is the picture before the counterpulsation was. And this is the echo image again after the counterpulsation was complete, and compare it with what we had after the before the counterpulsation was. You can see the drastic improvement in the heart pumping which was there. So we did again assess, should we leave him like this or should we do something else? We did a calculation again. The risk of perioperative mortality had come down by Euroscore to just less than 2% instead of 15.2. So it was left on the patient's decision what to do. He said that he would like to go ahead with the bypass surgery. And so on 18th of January 2018, we did the bypass. 3 grafts are given, tolerated well, extubated the next day, and he has completed 4 years of his follow-up. He's doing extremely well and perfect. So this is what the treatment of counterpulsation was. Let me also quickly share what this was not an anecdotal case. In our hospital for last 10 years, we have been doing counterpulsation, and I'd like to share small data for what our experience been. Out of total 655 patients, 553 patients completed the treatment. And out of the 553 patients, 371 patients were with ejection fraction less than 45. So this is the data from all people who had LV ejection fraction less than 45 presenting to us for counterpulsation. 91% were male, and age was around 60.9. The maximum age we have done is 91, and the lowest age is 22. This person was a dilated cardiomyopathy patient. Ischemic etiology was there in 95.4% of patients. Rarely we have been using this as an indication. However, 17 patients, a total of 4.6% of patients, were non-ischemic cardiomyopathy as well. The risk factors were the conventional one, but hypertension, diabetes was very common, nearing 70% of population. Majorly about 50 to 60% people had a prior angioplasty or bypass surgery, and triple vessel disease was present in 73% of patients. Ejection fraction less than 25 was in 38.8% of patients. Almost 40% patients had ejection fraction less than 25%. So this is what we had. The indications why we are using in our clinical practice. If we have a diffuse disease, we cannot contemplate angioplasty or bypass. Then we offer EECP to them. If we have a person who has had comorbidities such as kidney dysfunction, liver dysfunction, or something else which is prohibitive risk for CABG, we do. About 9% of patients were such. Patients not willing for bypass surgery, 2.3%, and that is patient's discretion. They don't want to bypass surgery. And preparation for bypass, we have, just like this gentleman, SMJ, we have many of the patients who actually are too sick for bypass surgery. We do counterpulsation, stabilize them before the bypass surgery, and then do the bypass surgery in them. Nearly 4.6% of patients were in such category. If you look at during the course, there was hardly any change in the medication, but there was a drop in diuretic intake by nearly 5%, which also means there was improvement in heart failure situation. If you look at the angina score, there was the green bars are the post and the red bars were the to begin with. So more of the patients were NYHA 3 and 4 to begin with, and they became 1 and 2 without any angina after the completion of the ECP. If you look at breathlessness, the marker of heart failure, you can see the similar kind of period that most of the patients were NYHA CCS class 3, 4, and they actually reduced to 1 and 2 after the ECP therapy, even though they were having severe LV dysfunction. Their activity scale did improve from the low scores to a higher score towards the completion of the ECP's protocols. And 6-minute walk test also improved substantially in all the patients, and in 95% more or more the patients. And the maximum improvement was there when there was poorest. The blue marker is what happened before the counterpulsation, and this is the substantial improvement in their 6-minute walk distance, hall walk distance after the completion of ECP. So that was a substantial improvement, and the sickest population did the best. So in a nutshell, what the parameters did improve is, if you look at dyspnea score, on an average it was 2.27, and it reduced to 0.89, and the p-value was as low as 6 zeros, and 29 zeros were there. So this was a substantial improvement by ECP. The 6-minute hall walk distance on an average from 293 improved to 441, almost 150 meters improvement on here. That means 50% improvement, which is substantial. Again, p-value area is significant. Activity score improved from 3 on average to 6, almost 5.7 on an average. Ejection fraction, there was a 5% increase on an average from 30.7 to 35.7, and this was irrespective of ejection fraction bracket, again statistically highly significant. There was a half a kilo weight loss, and the systolic and diastolic blood pressure, both of them significantly reduced after the counterpulsation therapy. So these were all markers which were suggestive of improvement in heart failure. Also, we had a sub-analysis on the kidney functions because there were 74% of patients, 74 patients who actually had concomitant renal dysfunction, probably AKI. And this I published in American Heart Association. And this is what it showed that pre-ECP, the blood urea was 70.6. It reduced to 64.6, but it was not statistically significant, but there was 8.5% drop in urea. If you look at the creatinine, there was 9.1% drop in creatinine, which was statistically significant in that small number, 74 patients only. EGFR, there was 19.5% increase in the EGFR from 39 on an average to 47. And if you look at the total number of people, nearly 50% of people, 55% of people did show remarkable improvement in the EGFR, almost normalization. So that is something which was important. Last but not the least, why do the people improve by ECP in heart failure? Is it just a sort of ischemia management or is something else? So if you look at, we have various mechanisms of improvements, but what I want to say is I want to put some light on for basic heart failure improvement is the fact that it improves the vascular capacitance by increasing the effect of nitric oxide. And this is the data which I have taken from European Heart Journal from control to day one, first week and first month. There's a consistent improvement in the nitric oxide effect, which would increase the vasodilation and reduce the afterload. This is one of the mechanisms. The other thing is the CGMP, the cardiac contractility, improves. The angiotensin 2 activity, which is the hallmark of pathophysiology of heart failure, also substantially reduces over the period of time after 36 hours of ECP, which has been noted. Looking at the NT-proBNP or BNP levels, there has been remarkable reduction in BNP levels after the ECP therapies. We have not measured that in our population, but there is data to suggest it's a p-value of significance. What we have done in our a small group of 36 patients in our population is we did echocardiographic assessment of vascular functions and their outputs. So during the counterpulsation, there is almost 20% increase in the outputs in various forms. We did ascending aorta, descending aorta, common carotid artery, renal, and as well as SVC, everything suggestive of nearly 20% increase in cardiac output during the counterpulsation. That means it is reducing the afterload, it is increasing the cardiac output, and that's how it may be improving the heart failure. There is data also to suggest that if you look at left ventricular end diastolic pressure during the counterpulsation, it substantially reduces after counterpulsation, which is again a marker of heart failure. So there is lab data to suggest that the heart failure markers do improve after counterpulsation, ischemic reason or non-ischemic reasons. So this is what we have also done in a few of our patients, but this is the data I'm copying from Sorano et al., which suggests is that the exercise tolerance improves. We have done it in 6-minute Hallmark test. They have also done in VO2 max, which has shown substantial improvement after counterpulsation at 1 week and also at 6 months. This also reduces the endpoints in the form of reducing the event rates of rehospitalization within 3 months to as low as 6.1% from 34% in this particular study. So that is something which is very important marker for heart failure patients. So, ladies and gentlemen, in my population, non-ischemic etiology, if it is there, when do I use those 17 patients? Those are patients where they were either waiting for heart transplant or ventricular assist device. They did not have the money for a ventricular assist device and were waiting for heart transplant and still symptomatic despite best medical management. And they were actually requiring stabilization for their heart failure pathology. But one thing I want to be very sure that everybody should understand, if I'm taking a person with heart failure, these are 3-4 points which have to be very carefully watched for. proper decongestion before we start the therapy. Otherwise, if the person has leg edema or orthopnea, we can worsen the heart failure symptoms during the counterpulsation. One of my patients actually stopped his medication. So I'm very keen and very particular that they have to be daily weight monitored. And if at all there is a chance or sign of increase in weight because of fluid retention, this has to be very early managed. Otherwise, the person can land up into heart failure precipitation. And judicious use of diuretics should continue during the treatment. So, ladies and gentlemen, this is one of the addition in our armamentarium for heart failure population. In ischemic pathology or non-ischemic pathology, majorly the ischemic pathology, taking the case of SMJ, which I was describing, the management should be, in my opinion, patient-centric. What is in the interest of the patient which should be given to that person. Based on the guidelines, yes, that can support us. What are available modalities should be helping in the totality of treatment of the patient. It does not mean which modality are we using. Whatever is suitable for the patient should be used. Whatever has to be good in the interest of the patient should be used. So this is what we call as a team approach for the heart failure management. Thank you. Thank you for your attention. I'll stop here and take questions if there are.
Yeah, thank you so much, sir, for a nice presentation. Yes, we'll have question hour session. Yes.
Yes, sir. Can I permit?
Yeah, I'm seeing a couple of questions here. Vijay Thakur is asking what we do in cardiomegaly. So Vijayji, cardiomegaly is something which we have to be very clear about. It's not a disease, it's a manifestation of a disease. Cardiomegaly could be there without systolic dysfunction. If a person has leakage of aortic valve or mitral valve, the person can have cardiomegaly, or PDA or VSTs, the person can have cardiomegaly. Those may not be the right choice to do counterpulsation, because when we do counterpulsation, the leakage of the aortic valve can increase. So cardiomegaly is not the diagnosis which I'm going to act upon. If the cardiomegaly or enlargement of the heart is because of the weak heart syndrome or of ischemic or non-ischemic reason, without any limitation or contraindications for counterpulsation, I can do EECP in them. As far as management is concerned, treatment is concerned, obviously blood pressure management on all those treatment lines which I said, the ACE inhibitors, ARBs or ARNIs, beta blockers, MRAs and SGLT2 inhibitors would come to play if the ejection fraction is lower than 45%, definitely, but not in general, which I would like to say here. We have to be very clear what we are looking at as cardiomegaly diagnosis. Somebody has asked kindly share the published paper. Well, the data which I have shown is just the interim analysis which I did 1 week back when Sanoj asked me to present this data. So I took out, everything is computerized. I am writing on that, and as soon as the article is published, I'll let you know about it. The initial data, the American Heart Association, that data is available on the web. Which company ECP equipment do you use, sir? I've been using Vaso Medical equipment, enhanced external counterpulsation, but I am very sure that everything should be acting in the interest of the patient. Whatever equipment you have, you can use the similar way. Earlier patient with already on stent, then what we do? If the patient is already on stent, there are two situations, three situations rather, when I would still do counterpulsation. If the person is still in heart failure, although angioplasty has been done, but the person's breathlessness is there because of damage to the myocardium, because if the person is symptomatic, I may take counterpulsation as an add-on to the guideline directed medical therapy. That means the person has to be on the best possible medical therapy and the person still remains symptomatic, then I may add counterpulsation to help the patient's symptomatic status. Second situation would be if the person has underlying microvascular disease. That means when you do the angioplasty, you open the main vessel, but the branches may still be narrowed and there may not be very good peripheral perfusion into the heart. And ECP may help in those situations. In many of my patients, I have taken when there was microvascular ischemia despite angioplasty, and that's why you saw 38% of patients had previous angioplasties and they were still symptomatic, blasting one of the vessels. But other arteries are still diffusely diseased and causing the symptoms. I can do the counterpulsation then. So there are a few things which we can use. Uday Shah, he's asking, sir, please, the pulse rate above 100, nearly 120, what is the treatment of tachycardia? Udayji, this is a very good question. For all practical purposes, a person who has high heart rate is a potential hell for that person with heart failure, because higher the heart rate, more the exhaustion of the heart and more worsening of the long-term outcome. High heart rate could be because of two reasons. One is sinusoidem, when the normal electrical pathway is maintained. And the other one is atrial fibrillation, when the upper chamber is fibrillating at a rate of 600, but the lower chamber is beating at 100, 120. If the person has sinusoidem, then we can have beta blockers to reduce the heart rate if the person tolerates them. If the person does not tolerate them, then ivabradine is another drug which can be added to reduce the heart rate. But if the person is in atrial fibrillation, beta blockers role is lower. Ivabradine is not effective. Still, beta blockers has to be given to reduce the sudden cardiac death syndromes. And amiodarone and digoxin could be the drugs which could reduce the heart rate, but then we hover around 80s instead of bringing down below 70.
Yeah, hello, sir.
Dr. Greiger Cherry, he's asking, have you seen patient developing chest pain during ECP session anytime? Dr. Greiger, yes. And when I actually see such kind of patients, it is usually due to systolic overload. If we are not very careful and we do not have when we have to adjust the duration of the compression, we have to adjust the inflation and deflation. If we do not adjust the deflation before the cardiac systole starts, that is the time that the person can have systolic overload and the person may land up in angina. And I have had a couple of patients. So in that situation, what I have turned and done to my best practice is not to go beyond the P wave, because this is the big problem. When you see the pulse oximetry, you see the diastolic augmentation, and more the diastolic augmentation, you are happy. But you do not realize that the diastolic augmentation may actually impinging on the next systole. And this is 1:1. So that means there is no normal cycle to compare it with. And that is why I have made it a point. I do not do the deflation beyond the P wave. So at the P wave, early part of the P wave, and then I make sure that there is no systolic loading to prevent the person from having angina. Avdesh ji asks, my ejection fraction is 38% and CKD. Incidentally, I have also done one of the persons with the same name, counterpulsation. This person did well for a couple of years, but then that person had to go for dialysis because of natural progression of kidney disease. But he had good 2 years of addition for his heart failure function and normalization of the kidney function as well. Kapil Kumar has a question. I have 40% ejection factor, have breathlessness, blood pressure within limit under medication, need your help. वेल कपिल जी, दिस ये बहुत इंपॉर्टेंट सवाल है आपका। आपका इजेक्शन फ्रैक्शन 40 है, इसका कारण क्या है, क्यों 40 हो गया? आपको सांस फूल रही है क्या? आपका ब्लड प्रेशर की मात्रा आपकी कितनी है? देखिए, एक चीज की, एक बंदा 110 भी नॉर्मल मान लेगा, बट जिसका हार्ट वीक है उसके लिए मुझे 90 का भी प्रेशर हाई हो सकता है। मैं कभी कभी तो 80 तक ले जाता हूँ। उसकी टॉलरेंस के ऊपर डिपेंड करता है। सो ये सारा चीज डिपेंड करता है कि आपका क्या कारण था हार्ट वीक होने का, क्या दवाइयां चल रही हैं, कोई और चीज तो हम मिस नहीं कर रहे हैं, एनीमिया तो नहीं है, आयरन डेफिशिएंसी तो नहीं है। कई सारी चीजें हैं देखने वाली। एक बार पूरा पैरामीटर्स देख लिया जाए तब हम उसको कर सकते हैं। और ही वाज आल्सो आस्किंग अबाउट द कॉस्ट। कॉस्ट भी वेरी करती है। हमारे हॉस्पिटल में इसकी कॉस्ट करीब 1.1 lakhs के करीब पड़ता है, but there are centers who are doing at lesser cost also, but this is variable, hugely variable. फैजल अली कहते हैं, in which patient ECP is contraindicated? Very good question, फैजल अली साहब. So there is definitely a shrinking of the contraindications lists. If you look at the data which I have, the peripheral arterial disease was once upon a time seemed to be a contraindication. I have done patients, at least 6 patients with contraindication. That means with peripheral arterial disease. They had poor augmentation, but they did extremely well. Their even peripheral circulation improved, and their ulcers, which they were developing in the foot, also stabilized. So that is something, because they didn't have any other option. We could do them with the perfect consenting and everything. And me would be artery. That means aortic regurgitation would be a contraindication. PDA would be a contraindication. AV fistula would be a contraindication. Then the as I said, AP window would be a contraindication. If the person has ulcers on the legs, which is not allowing me to tie the cuff, I would not do that. Deep vein thrombosis, which should be absolute no-no. Pregnancy is something which I have not been doing at all, the counterpulsation in. And these are something which we have to be very clear about. A person should not be orthopenic. That person should be able to lie for an hour to tolerate the counterpulsation. There should not be any leg edema, which because once we compress, the edema fluid would go into the vascular compartment and can precipitate heart failure. All these are contraindications. Extreme high heart rate or atrial fibrillation, when the RR interval is varying, we cannot do counterpulsation. If we have extreme hypertension, that means the blood pressure above 170 and 100 millimeters diastolic, I would not do the counterpulsation. Stabilize it first and then do it. So these are the contraindications which I've been looking very clearly in my clinical practice, not doing it. Do you avoid, Dr. Greiger Cherry again is asking, do you avoid ECP in any case based on location and degree of coronary artery blockage? Oh, well, yes. That's a wonderful question, Dr. Greiger. Thanks for asking that. You know, I would again reiterate what I said in the last slide. Every treatment should be in the interest of the patient, not in the interest of the treatment modality. I'm not interested in ECP. I'm interested in the patient's life and the patient's quality. So if the patient needs a bypass surgery, if the person has a left main disease or a thrombotic lesion, I would be refraining from giving the hope to the patient that you can be treated by counterpulsation. You know, if the person drops in dead the next day with the pseudo confidence, that's wrong. So if the person has a high risk, I would definitely not wish to do that. Second thing is, this question is also important to understand, but largely the ECP works through the natural bypass mechanisms. That means the collaterals from open vessels, open branches to the closed branches territory. And if we have a proximal triple vessel disease, all three arteries are blocked without any major branch coming from the open territory. This is a bad disease. You would not do well. So I would refrain from doing that. Which test do you do for collateral arteries? So that's a good thing. You know, collateralization is an indirect thing as well as direct thing. The direct thing would be evident on MRI flush or a therium flush. But the direct thing is something which indirect thing is more important, that the person's symptomatic status improves, the person's functional tolerance improves, ejection fraction improves, and if you do the contrast injection, the perfusion in that particular area improves. So those are various things which I have been using. Dr. Greiger, thank you for raising this wonderful miss from my side, which was there. Hypertrophic cardiomyopathy is one of the things which I missed to say that I'm not going to use it in. But aortic stenosis with failure, I can use after the decongestion level, because at least coronary circulation, it can still improve. So Dr. Greiger did say, can we try ECP for hypertrophic cardiomyopathy with heart failure? With heart failure, well, I have not tried it, Dr. Greiger, to be realistically true. But a person who has hypertrophic cardiomyopathy and landing him into heart failure without an obstructive feature is more likely a dilated cardiomyopathy with hypertrophy syndrome. And I can definitely give it a try. There should not be any obstructive feature in hypertrophic obstructive cardiomyopathy type picture. Hypertrophic cardiomyopathy without obstruction and in dilated phase or heart failure phase, I can try, but I have not tried as of now in my clinical practice. I don't see any more questions here. Dr. Sanoj.
Yes, sir. There is some question. I think Dr. Faisal ji, I think from Dubai, he asking some question.
So Faisal asked about the collaterals. So I did answer about that. So the last one is from Dr. Abdesh. Which hospital treatment ECP in Delhi? So there are a lot of hospitals. You can have the list. Faisal, you can upload this. There could be a ECP site which can actually be created for the patient's awareness also.
My question is different, Dr. Sanjay Mittal. I asked about Scubitrol and Valsartan used in congestive heart failure patients. What is the result?
No, I'm sorry, there are two Faisal. This is now Dr. Faisal from Dubai speaking now. Before there was one patient from Faisal.
Okay. So Dr. Faisal, I did try to answer that. This is what we call as ARNI, the sacubitril and valsartan combination. Sacubitril is neprilysin inhibitor and valsartan is the ARB, the old and gold ARB heart failure medication. I have been using ARNIs, that means the combination of sacubitril and valsartan, day in and day out. The only problem is it's a costly drug and it's a lifelong drug. So that means many of people would not tolerate it. Second thing is I have to be very carefully be watching for the blood pressure changes because it is more hypotensive. It reduces pressure more than the ACE inhibitors, ARBs. So I've been using this drug very frequently in heart failure.
Okay, that's good. But the thing is that when we use this drug, we have to cut down the other diuretics and other hypertensive drugs. So, but we are, actually what we are mistaken, we are doing it with spironolactone. That also decreases the blood pressure. So we have to reduce that and have to increase the dose. If you see literature, the company which is promoting in globally is Novartis, and they are actually giving the best knowledge of this drug. I have been using it in my patients and I've got good result. The thing is that it's very expensive these days. So your supplement is valuable.
Yeah, that is what I think. If you look my prescriptions for heart failure, there would be around 40% of people who would have the prescription of ARNIs, mainly because the cost is prohibitive for the rest of them, and the concomitant CKD or AKI, which is there in at least 20% of people who would not tolerate the ARNIs, EGFR less than 30. So those people I would not give. The other thing is about the diuretics part. the concept, whatever Novartis has been given or anybody is being given, it does not change the paradigm. Diuretics are the unnecessary drugs. The other way. They are the necessary evils. That means they are only drugs for the symptomatic relief, not for the therapeutic purposes. In any case, my prescriptions would reduce the diuretics as soon as the person's dry weight is there. If sans ARNIs, sans SGLT2, and you're talking about the ARNIs, thanks for raising that question, but SGLT2 are much more notorious to cause dehydration. So whenever I have addition, I do reduce the loop diuretics in them about 20-30% and ask them to do their weight monitoring every day in the morning. If the weight increases, increase the diuretics. If weight reduces, then reduce the diuretics. So that is something which is a part and parcel of the heart failure management. The topic today was basically on the EECP. That's why I didn't cover those things.
Dr. Sanjay Mittal, very important question. When we start a heart failure patient, what we do, we cannot start with the 1 hour treatment. We have to gradually, your comments on that?
Very good question. It's not only the heart failure. In general also, especially the elderly people, the one I was talking about, the elderly, the most elderly one, 91 years, I slowly and slowly over a period of 1 week or 2 weeks to 200. That is the maximum he tolerated. And this is exactly what I've been using in heart failure patients also, and that is why we have to start with a lower pressure and then build it up. Everything depends on the patient's tolerance. Yes, if the patient is tolerating 120, I'll start with 120. If the person is tolerating 200, I'll start with 200, but I would not start with 300 on the day one. You are absolutely right on
that. Would increase the treatment tenure. I mean, it would.
Correct. That is precisely why we need to increase the pressures as soon as we can, so that we can do the best for the patient. You are absolutely right on that.
Someone offer redo sessions every year.
So have 3 aspects to that. Point number 1, whenever I do a EECP in my patient, I tell that person that this is for a walking program, 10,000 steps a day, as close to that. If you keep on doing that, there is very likely you would not require the recurrence or repeat of the treatment. And this has been there in my clinical practice. I possibly shared the data, I think, but passed on the slide hurriedly, where in my clinical practice, nearly 20% of patients are such who actually required the second treatment at the end of 1 year. And majority of these people were such people who actually stopped exercising because of one of the reasons, because it was too cold, or they had some sickness, or there's some pretext or the other, that they stopped exercising, and then the collateral start reducing, and then we have to recharge them. So I call that as a recharge therapy. I started with 2 weeks therapy rather than 35, 14 days therapy rather than 35. Usually that recharges them, and they are back to square one.
Congestive heart failure, they basically ask the patient, why not go for CRT or ICD device, and then you can go for EECP. So is that it? Or
there is all permutation combinations in my clinical practice. There are people who had counterpulsation before, because in my opinion, if you have a mechanism by way of which you can improve the cardiac contractility by making the ejection fraction go above 35%, it becomes not a primary indication for ICD. So there are a lot of people in my clinical practice where we started counterpulsation, gave them 3 months of a watch out period. Say, for example, this SMJ. If this person came to me as a heart failure possibility, I would not have given an ICD. But if day one the person said, please get an eye. One of the three reasons. One, he had episodes of syncope, monitored ventricular arrhythmias, tachycardias, or a huge bit of scar system, which I have to basically look at the improvement in heart failure symptoms by doing counterpulsation. CRT would be there for left bundle branch block. In my opinion, if the person is ischemic cardiomyopathy, I'll do the counterpulsation first and then look at CRT. If the person was non-ischemic cardiomyopathy, this ICD CRT would be the first choice. Look at the improvement with CRT. If there is still symptomatic treatment, then I'll do the counterpulsation. So there is in the interest of the patient, we can change the decisions from time to time. That's absolutely true for me.
Thank you very much, Dr. Sanjay. It was very impressive discussion with you. And in future also, we would like to add that you can have ECP talks on regular basis. Thank you.
Absolutely.
Very much.
It's my pleasure. Thank you very much if I was of any help.
Hello, sir.
Yes.
Yes, sir. So with your due permission, can I ask something?
Yes, please.
Yeah, yes, sir. First of all, a very good evening to you. And it was really a informative and it's really a knowledgeable session regarding the ECP. And sir, I really commend that you have aware us about this therapy. It's a non-invasive therapy instead of a bypass surgery. Actually, sir, I just have a question. Like, my father has two arteries got blocked. RCA 100%, LAD 100%. So ECP इस केस में सर बेटर रहेगा या bypass surgery? क्योंकि डॉक्टर bypass surgery के लिए ही बोल रहे हैं.
Oh, so this is a good question. See, when both the arteries are 100%, there is something good which is happening. That the 100% artery cannot block any further, right? It cannot become more than 100%. So yes, there is no risk for a heart attack, right? From these two arteries. Okay. Problem comes from the third artery. If the third artery has a minor plaque or a little bit of blockage, for 40 or 50%, that can cause a major catastrophe. These 200% blocked arteries cannot cause heart attack. They can cause heart failure and angina, and ECP is a very good treatment for them.
Okay, but sir, मेरे father का 30% है और PET scan करा है तो hibernating myocardial, high chances of revascularization.
Achha. So if the hibernation was huge, what is the age of your father?
63 years.
And how active is he?
Sir, active तो काफी है, but अभी बीच में अल्कोहल कम कर दिया, पहले अल्कोहल ज्यादा लेते.
डायबिटीज?
फादर को
डायबिटीज है
जी.
कंट्रोल रहती है कि नहीं?
हाँ, डायबिटीज कंट्रोल रहती है, बीपी भी कंट्रोल रहता है.
वेट कितना है?
65 to 70 kg.
Not too obese.
जी?
बहुत मोटे नहीं है मतलब, है ना?
बहुत मोटे नहीं है सर.
हाँ, so अगर ऐसा है, see both the options are available to us. ECP भी करा जा सकता है और बाईपास भी करा जा सकता है, बट अगर इजेक्शन फ्रैक्शन 30% है और हाइबरनेशन है, so bypass is definitely going to be a better choice in the long run because it is a class 1 indication. अगर पूरे global data देखें, blockages के साथ अगर heart function कम है तो उसके improvement होने के chances बेहतर होते हैं. अगर आप देखें ये वाला केस जो मैंने आपको दिखाया था, it's almost again not 100% blockages but almost 90% blockages everywhere. This person improved. So if the sleeping muscle is there, that means muscle is not dead, it's likely to improve. We can do all three combinations if it's totally patient's disposal. If the person does counterpulsation, improves the heart function, at least the surgical risk would come down. And usually in such kind of people, we do counterpulsation, then stabilize them and do the bypass surgery if they still require. If they become perfectly okay, they correct their habits, then it's fine. But I am very cautious in people who are diabetics, because diabetics people usually sometimes do not complain of pain. And in these situations, it's always better to actually go towards bypass surgery rather than just as a final treatment, rather than just EECP. EECP may be used for a stabilization purpose for them.
Okay. तो सर अगर इसमें ECP करा देंगे तो कोई इसका रिस्क तो नहीं होगा?
रिस्क कुछ नहीं होगा। रिस्क तब होगा अगर उसको बाय चांस उनको एओर्टिक रिगर्जिटेशन भी हो या कोई वीनस थ्रोम्बोसिस हो या लेग अल्सर्स हो, वो जब तक देखेंगे नहीं तब तक पता नहीं चलेगा।
नहीं सर, एरोटिक वॉल्व में कोई लीकेज नहीं, इको की रिपोर्ट में भी उसमें क्या देयर इज नो ब्लड क्लॉट, EF 30% है, ग्लोबल हाइपोक्सिमिया है।
हाँ, तो then ECP is not a contraindication at all. और पेरिफेरल वेन्स भी ठीक है ना, कोई वीनस थ्रोम्बोसिस वगैरह तो नहीं है ना पैर में?
नहीं सर, पैर में कुछ भी नहीं है, ग्लोबल हाइपोक्सिमिया है, पेट स्कैन में हाई चांसेस ऑफ रीवास्कुलराइजेशन लिखा है।
वो तो पेट स्कैन बताया आपने। आई थिंक ECP से इंप्रूवमेंट आना चाहिए। मेरा एक्सपीरियंस यही कहता है कि उससे इंप्रूवमेंट आएगा। इंप्रूवमेंट आएगा तो सर्जिकल रिस्क कम हो जाता है।
हाँ, और लिखा है मिसमैच डिफेक्ट सीवियरली रिड्यूस पर, वो
बता दिया, हाइबरनेशन बता दिया आपने, तो दैट इज द सेम थिंग है ना?
जी सर, एक मेरा आपसे क्वेश्चन है सर, ये सर इतना इफेक्टिव ट्रीटमेंट है तो सर ये इंडियन कार्डियोलॉजिस्ट इसको रिकमेंड क्यों नहीं करते हैं सर?
ये बहुत अच्छा क्वेश्चन है आपका। अब मैं इस समय जो जवाब देना चाहूंगा वो कुछ लोगों को शायद अच्छा ना लगे। आप न्यूज देखते हैं?
हाँ, देखते हैं।
वो न्यूज
Hi doctor, can you speak in English?
Okay, so you see I'm sorry. So what I'm going to speak now, it may not be appealing to many of the people. I was asking him, do you see the news? He said yes. So my question to him was, in India, who is the newsmaker? Is that newsmaker at all concerned about you or your health? The newsmaker is more concerned about his pocket, because producing that news is giving him his earning, his bread and butter, right? The same thing is there, whatever the media or for that medical media or scientific media is also sponsored, right? Most of these trials are done by companies who are run by pharmaceuticals and by stent companies. And they would obviously mean that they have to somehow prove that their product is right, then only the things are going to sell. Otherwise, tell me, there are 3 major trials: the Courage trial, the FAME trial, and now the ischemia trial. None of these trials show that in people who have stable coronary artery disease, bypass or angioplasty is better than medical therapy. None of these trials. But still, when we go to any physician or any cardiologist or any surgeon, when they see blockages, oh, you have to get bypassed or you have to go angioplasty. So what I'm trying to say is there less said than many a times. The problem is because of the fact we are listening to what we are told. We are not reading between the lines. So if we look at the literature, we'll come to know the reality. The reality is, in stable coronary artery disease, medical therapy is as good as angioplasty or bypass surgery, rather safer. Until unless the blockages are critical in left main or with a heart function, just like your father had, the heart function was weak and the person is a diabetic, that's a different situation altogether. But in stable coronary artery disease, medical therapy is as good. So lesser said and done, who is going to sell counterpulsation? Because it's a longer treatment. It takes about 35 days on an average. Progress is slow. Over a period of 10 days, it takes about a week for you to realize that you have some benefit going on.
Yes, sir.
So there are certain things. If you look at the long-term data, I think there's no second thought for me. If a person has stable coronary artery disease, ECP is my first choice before with the angioplasty or bypass until unless the person has a critical or life-threatening lesion there.
So further, I would like to add on.
Dr. Mittal?
Yes.
Can I get a word in before we take too much of your time and we don't have any more airtime?
Yeah, please go ahead, please, Doc.
Okay, Dr. Mittal, on behalf of the International ECP Association and our president and the members, we'd like to say thank you to you. Absolutely brilliant talk, and seem to be a man who speaks my own words. I like the term that you use, that you're interested in what's good for the patient and not what modality you have to sell. I think if all healthcare workers think in this way, we'll be heading in a good direction in the future. So thank you very much. A simple question that I'd like to ask you, just to tickle your brain. Yeah. From a cardiology perspective, I know that we look at ECP as a preconditioning to precondition the patient for stent insertion or bypass surgery should the need require.
Yeah.
Do you think we should be looking at ECP as well as a rehabilitation post-operatively? Because from my experience in bypass surgery, using ultrasonic flow meter after we do the grafts, we noticed that if, hypothetically speaking, we had to do 4 bypass grafts, of them 2 work and 2 don't work. So those parts of the myocardium that could not be perfused during grafting because of microvessel disease, it will be beneficial for these patients to undergo ECP in the post-operative period as a rehabilitation. And I'm asking for your opinion, and this is not to push the...
No, that's a wonderful question, and thanks for asking that question. I have two parts to that. Point number one, the major concern for me in situation like this is that many of such people have venous grafts, and the legs are actually operated upon, and at least for about 6 weeks or so, it's going to be painful for them to actually get compressed. So I have one patient where
Sorry, please mute your microphones.
Somebody muted me. So what I was saying is, because the major handicap is because of the fact that most of these people who have diffuse coronary artery disease have venous grafts rather than arterial grafts, and the veins are taken usually from the leg, and that is a painful area at least for 6 weeks after surgery. By that time, any which ways natural collateralization happens. I remember one case though, where the patient was too sick and did not have good revascularization. So I did the compression of the thigh and the buttock cuff, and just wrapped up the leg cuff outside, so that the counterpulsation did go on in that patient, and that person did reasonably well. However, in the situations like this, I have been very fond of using 3-4 compounds: nicorandil, trimetazidine, ranolazine, and other drugs, which can help to improve the microcirculation, just like you might be doing in your practice as well. But that was a wonderful question.
Thank you, Doc. Nice to have you here, and I hope we'll hear much more from you in the future. God bless you.
Thank you. And I was appreciating your invitation also.
Sir, is flat regression possible through detoxification?
You have to be a saint. You have to go to the Himalaya mountains and spend the rest of your life there. The plaque regression can happen. You have to eat, stop all the things you like to eat. You have to stop using mind more than your body. You have to start using your body more than your mind. Walk for at least 10,000 steps a day. Stop using your car. Stop using your remote controls. Go out, play games. Hit the bed at about 7 p.m. and wake up at about 5 p.m. Do yoga meditation, take statins and control your blood pressure, diabetes and all, yes, plaques can regress.
Sir, actually, some of the EECP centers are using their methodology, like they will add a detoxification therapy, like they will give 40 35 sittings. I didn't want to take the name and I don't want to expose. I'm just asking a formal question,
that is not detoxification therapy. That is a calcium chelation therapy. It does take out the calcium from the various tissues of the body, specifically the intima, which is calcified. I'm not very impressed with that therapy because it can lead to make the plaque more vulnerable. A calcified plaque may be less vulnerable, less prone to injuries. The soft plaque may be more vulnerable. So I'm not very impressed with that data. So I limit myself to what I'm doing, and I'm impressed with the literature, which I experienced that.
Okay, sir. One more important question. What's the role of EECP according to a percentage and lifestyle and food and nutrition in the course of developing a heart failure, like 30 to 40% to 50%?
I couldn't get the question. You can repeat the question, please.
Sir, how much is the success rate of an EECP machine rather than a food, diet, and nutrition?
So again, this is a wrong question because a human being is a human being. You'll continue to eat, you'll continue to walk, you'll continue to maintain your blood pressure. If you don't control all those things together, no treatment in this world would be good. So you cannot be singling out one therapy and say that I would continue to indulge in all the wrong things, only ECP, and that would help. No, that's not the right way. And the other thing is the improvement of the myocardium is dependent upon a very clear understanding of one point. Dead tissue can never be revived. There is no treatment to make a dead tissue alive in the world by any doctor. If anybody says he can or she can do that, he's fooling you. Dead tissue is dead. If your skin is dead, it drops down, you cannot make that skin cell alive. There could be new skin which can come up, but that skin would not come alive. So heart muscle also, if it is dead once, it would not come back to life. However, just like you were saying that your father had hibernation, that means it's not dead but not moving because of lack of blood supply. That can be revived because it's not dead. So that is why when we predict what kind of outcome we are expecting out of counterpulsation, it largely depends how much muscle is dead and how much muscle is alive. And that is how also the role of a cardiologist and a physician comes into play. Okay.
Okay.
Thank you so much, sir. I think we're crossing the time now.
Yeah.
It's a very wonderful and very informative. They must learn something because it's a big topic. So I think we need one more session of your hope. So if you have time. So
no problem.
It's a very wonderful, very informative session. Yeah, thank you so much for giving your time, sir, Dr. Sanjay Mittal. We appreciate you for this and hope you good luck in the future. Thank you so much, sir.
Thank
and
you
thank you all the participants who joined this webinar. Yeah, okay. And thank you everyone. Have a good day. Thank you.
Thank you. Bye-bye.
Yes, sir.